Okay, guys, here's your B for today. B is explaining how childhood adverse childhood experiences um add to or linked to um, mental health issues later in life. So I'm going to discuss that for you and for B. So here we go. Short answer, yes. Multiple research studies show that adverse childhood experiences significantly increase the risk of co-occurring chronic physical disease and mental illness in midlife later. Relationship is robust across cohorts, persistent after adjusting for some confounder and appears dose responsive. More ACEs, higher risks. Summary of evidence. The large cohorts and registry studies report that people exposed to childhood abuse, neglect, household dysfunction, or other ACEs have higher rates of both psychiatric disorders, especially depression and chronic physical conditions, cardiometabolic disease, arthritis, asthma, obesity, cognitive problems. Decades later, a population study of 1,026 women followed for a median of 21 years found that those with two or more ACEs developed chronic conditions faster and had higher incidence of 10 of 18 measured diseases. Twin design and very large registry analysis. Over 25,000 twins in one study confirm a dose response linked between ACEs and later psychiatric diagnoses, while also showing that shared genetic and family environmental factors explain parts, but not all, of the association. A longitudinal analysis reported specifically that childhood trauma predicts later coexistence of depression and chronic physical illness, highlighting the combined burden rather than isolated outcomes. How this link is thought to arise: biological embedding. Chronic early stress alters stress response systems HPA axis, immune function, pro inflammatory profiles, and metabolic regulation, which together raise vulnerability to both mental illness and chronic somatic disease. Behavioral and social pathways. ACEs increase risk behaviors, smoking, poor diet, inactivity, reduced educational uh, attainment, and socioeconomic opportunities, and limit access to supportive relationships and healthcare, each amplifying long term disease risk. Potential implications. Prevention and early intervention matter. Policies and programs that reduce child mistreatment and strengthen proactive relationships can lower long term multi-morbidity. Clinical practice. Clinicians should consider ACE histories when treating older adults with multi-morbidity. Integrated care that addresses mental health, social needs, and chronic disease management is likely to improve outcomes. Limitations. Casualty is complex. Twin and sibling designs show that genetics and shared family environment account for parts of the association. So ACEs are one important contributor among several. Measurement issues. Many studies rely on retro, retrospective self reports of childhood adversity, which can bias estimates. However, caregiving evidence from prospective and registry studies strengthens confidence in the overall pattern. Childhood adversity is a strong dose dependent predictor of later life combined physical and mental illness mediated by biological and behavioral and social pathways. Addressing ACEs early and offering trauma informed integrated care across life course are key strategies to reduce this combined pattern or burden. Short answer: a large perspective population based cohort study found that cumulative childhood trauma exposure is associated with higher rates of adult psychiatric disorders and poor functional outcomes, work, social functioning with a dose responsive pattern that persists after adjusting for childhood risk factors. Study, study snapshots, design and sample, perspective, population based cohort followed from childhood into adulthood. 1,420 participants assessed repeatedly in childhood ages 9 to 16 and followed at ages 19, 21, and 25 and 30. Exposure. Childhood trauma was measured with structured interviews. Child and child and adolescent psychiatric assessment up to 8 times in childhood exposures were some some to create cumulative trauma count. Primary outcomes: adult psychiatric disorders, structured young adult psychiatric assessment, and functional outcomes: employment, social isolation, disrupted transition to adulthood. Key results: what the paper reports. Dose response association. By age 16, many participants had one traumatic event higher cumulative trauma predicted. Greater odds of adult psychiatric disorder. Adjusted OR 1 to 1.2 to 1.3 per exposure category and worse. Functional outcome: job instability, social isolation, robustness associations remained after adjusting for childhood psychiatric problems and family adversities, indicating trauma exposure contributes additional risk beyond baseline. Childhood risk factors. Why this matters: clinical screening for childhood trauma can identify adults at higher risk for persistent psychiatric disorders. Or illness. Functional impairment, trauma informed care, and early psychosocial supports may reduce long term burden. Policy and prevention. Reducing childhood trauma and strengthening proactive environments could improve population mental health trajectories and adult social occupational functioning. Strengths and limitations. Strengths: protective repeated childhood assessment reduces So reliance on proactive recall, structured diagnostic interviews across development, population based sampling. Limitations: cohort demographics, majority white in this sample, may limit generalizability. Residual confounding is possible. The adjusted ORs are modest, so trauma is one of several contributors to adult outcomes. Okay, guys, that's your B. I'll be back on with C shortly. Give me a little bit for a break, please. And I'll be back on with C for now. Gator Wellness. Take care, folks.